Good afternoon, friends and colleagues, and welcome everybody to this lesson that today will be held by Professor Bradley Yoder on a very hot topic, non-invasive respiratory support. I thank Professor Yoder for his collaboration to the UENPS webinar and enjoy this meeting. And now, as usually, I leave the floor to our chairman, Professor Stockdale. Thank you.
Thank you very much, Professor Moretti. Welcome back to all the participants from all over the world. And it's really a pleasure to welcome you to this session, which is the second lecture in the second module of this fine series. It's an honor to introduce the speaker of today, Professor Bradley Yoder. He is professor and division chief for neonatology at the University of Utah. And he graduated from the University of Pittsburgh School of Medicine. And he did his residency and fellowship in the Air Force at Wilford Hall Medical Center in San Antonio. And he has been involved in laboratory-based translational research and clinical trials research for over 35 years. He directed the neonatal primate laboratory at Southwest Foundation in San Antonio in Texas for 10 years. He has is now a collaborator in the premature lamb lab led by Dr. Kurt Albertine. Dr. Yoder is currently the Utah site primary investigation for the NICHD, Neonatal Research Network, and he has participated in numerous randomized trials. His topic today is about non-invasive respiratory support, the why, who, what, and when. So please, Bradley, it's an honor to leave the floor to you.
Thank you, Professor Sogstad and Dr. Moretti and Dr. Lista for this kind invitation to participate in this, I think, rather unique and promising learning session. So we will move forward from here. I do need to disclose some conflicts of interest just briefly, as I do receive some or have received research or travel support from Draeger, Vapotherm, and Fisher McCall. I do not think there will be any conflict in my presentation related to that, but these should be shown.
Professor,
So my objectives are shown. Yes.
Professor Yadi, sorry to interrupt. If you can first share your screen, please, from Zoom. Thank you.
My screen just shows my talk, so I don't have control over this screen.
Or if you, yes, if you can, first you have to go out from your presentation, enter in Zoom and share your screen.
Let me see. Okay. So
while he's doing that, I just remind you that you can send in questions during the lecture at the Q&A at the bottom of the screen.
There we go. Is that better?
Yes, thank you.
So I will show that. Conflicts disclosure, and then we'll go down to objectives. Thank you. My apologies. So we will briefly describe some of the abnormalities in adult lung function and the key processes of lung development, how basically preterm birth and some of the things that we either do to the babies or that are done to the babies simply because they're born preterm may have an effect on lung development and BPD, and BPD tends to be the primary abnormality of these preterm infants. We are trying to minimize by using different approaches to respiratory support, and in this context specifically, non-invasive respiratory support. The time is going to be somewhat limited, but we will talk about three most common non-invasive modes that appear to be available to many people at this point in time. But I will not specifically talk about nasal ventilation or nasal intermittent positive pressure ventilation, as that is a session for a later talk. So there's a tremendous amount of research, literature that is out there. If we tried to do it in 40 minutes, you'd be drinking from a fire hydrant. We're going to just give a trickle of information, and hopefully there will be enough to tantalize you, and you will continue to look for additional evidence on your own. So why are we interested in this particular topic? Specifically this problem, BPD. It is the most common morbidity that we have of the preterm patient, particularly the extremely small babies. It's been around for a long, long time, but it has changed also. So the problem, however, is that it is continuing to increase rather than decrease. And it's the only morbidity we have right now, at least in the European, Australian, and United States regions of the world, that is actually increasing rather than decreasing. So almost every other morbidity for preterm babies is getting less. This one is increasing. This slide basically just shows two of the studies that are out there. One from Canada, where there's over about a 10-year period been a 33% increase in BPD, and there's a similar increase across the United States within the neonatal research network, where we've seen a 30% increase over time. So it's not going away, it's only becoming more problematic, probably related to improving survival rates in this particular population. Now, what we're concerned about with BPD is what is its long-term effect? How does it affect the lungs? And there are numerous studies that have looked at the effect on lung development over time, and most of these studies actually are coming out of the European community and or Australia, where you have excellent follow-up systems for these types of patients. The important thing to note on this slide is that BPD makes the lungs worse relative to normal term babies, but even being born premature without having BPD causes a disturbance in lung development and lung function at a later life. And the question becomes, will a gentler approach to respiratory support improve this lung function over time? We would like to think so, but there is tantalizing data out of Australia by Professor Doyle and his group that actually shows some bothersome trends, and that is that increasing use of non-invasive support, in this case nasal CPAP, over a period of time did not actually demonstrate an improvement in lung function. In fact, there were some areas where lung function was even worse. It's unclear whether that's related to the population of babies and the differences in survival, the types of babies that are surviving, or other aspects of the neonatal care, but nonetheless, the evidence is not there to say that we're clearly making a difference. So to just kind of summarize that brief introduction, we know that BPD leads to significant lung dysfunction, that it's sustained into adulthood beyond just the newborn period. Even uncomplicated preterm births can lead to altered lung growth and lung function. And we have not demonstrated that non-invasive support prevents this to this point in time. So we have a problem. And the question becomes, what are the key aspects of lung development and preterm birth, and how we care for these babies that contribute to BPD? So it's important to recognize that BPD primarily occurs in those babies who are in what we call the canalicular stage of lung development. So this stage here, between about 16 and 26 weeks, when you're just beginning to get the formation of air exchange spaces, you still have a really thick mesenchyma. Gas can exchange across these units, but it's disturbed in terms of how that happens. We clearly don't have saccular formation and or alveolar formation. You still have lung development occurring. You still have the onset and development of the surfactant synthesizing system. So it's a very specific and unique fragile period of time. Now, what's interesting is that over time, there is a very marked change in the expression of genes within the fetal development, the fetal lung as it's developing. And this slide just kind of shows that picture. The red are areas of the genome which are upregulated, are expressing more, generating more, so you're getting more protein synthesis and formation and translation of the RNAs. The green are areas which are downregulated or suppressed. And simply going from 53 days of age to 140 days of age, you can see that there's a marked change in how gene expression occurs. This is a normal process. So some areas get upregulated, some areas are downregulated, and they all contribute to the normal development of the lungs, the alveoli, the vascular structures, surfactant system, etc. That means that any disturbance during this period of time, infections in the mother, nutritional deficiencies, exposure to, for example, even steroids, would cause perhaps significant alterations in this process and contribute to a disturbed development of the lung. Once the baby's born, we do things to those babies. And one of the things that we do that causes perhaps the most injury is we ventilate them with mechanical ventilators. This is a very elegant study that shows very simply in a very short period of time, this is a matter of hours, that in this case, a rat who's being spontaneously breathing has areas of upregulation in this area. Most of the lung is downregulated, but with simply just non-injurious, so volume targeted ventilation that is appropriate for the animal, massively changes the distribution of gene activity here. It takes most of these areas that are green, that are downregulated normally, and upregulates them. And most of this change contributes to an increase in pro-inflammatory molecules, immune-mediated pathways that then again can further alter or disturb normal lung growth and development. The same thing happens with infection, whether it's fetal and or postnatal infections. And the same thing happens simply by exposing the preterm lung to 21% oxygen or room air. This is a very elegant study out of Bernard Thibault's lab in Ontario, in Quebec, which shows that the normal kind of amount of function within mesenchymal stem cells of the lungs in 5% oxygen versus 21% oxygen, even 21%. So even room air exposure now in this fetal lung, which should not be exposed to that, disturbs lung development. So it's even worse, however, when you then expose them to higher levels of oxygen. So just to briefly summarize that, and this is kind of the why. Lung development is highly sophisticated. Complex pathophysiology occurs for BPD, though in general it is primarily inflammatory in nature. And many of the things that we do, and including just the act of preterm birth and exposure to room air, can disrupt lung development, impairing alveolization and vascularization. So our goal is to try and minimize as much as possible those factors that contribute to lung injury. And one of those factors, and that's the rest of this conversation, is the use of non-invasive ventilation to mitigate the more disturbing, injurious aspects of mechanical ventilation. So the specific goals of non-invasive ventilation are shown here. We want to minimize apnea, so we don't have to put a breathing tube into a baby. We want to optimize or improve oxygenation, improve ventilation, reduce the work of breathing, and minimize lung injury. And almost every form of non-invasive ventilation that we use can increase end expiratory lung volume and improve oxygen. So here we're looking at the effects of CPAP, which this is the change in end expiratory lung volume or resting lung volume, which as it goes up, it tends to improve oxygenation. It allows the lung to better exchange gas. So from baseline with CPAP, as you increase your CPAP, you get better lung volumes. And the same can be shown with nasal high frequency ventilation or other forms of non-invasive approach. They also can improve ventilation. That is, they improve tidal volume. So here again shows the effect of increasing levels of CPAP support on the relative increase in tidal volume. And with high frequency, with nasal high flow or high flow nasal cannula, as most people like to call it, there is an improvement again in tidal volume as you increase the flow support. And then all will minimize lung injury to some degree simply by removing the endotracheal tube and the effects of value trauma on the lung tissues. But that also contributes to reductions in nosocomial infection by bacteria migrating along the endotracheal tube. This minimizes inflammation. The real question becomes, are all approaches equal? Do they all minimize this lung injury in the same way? Do they all have their effects on oxygenation and ventilation in equivalent amounts? So when we get to that, I'm going to briefly just go through some of the types of equipment. And again, I'm not going to specifically talk about nasal ventilation, but we will go through some of the forms of nasal high flow therapy, of CPAP, which has a wide variety of interfaces and what I call drivers, systems that help you deliver that CPAP. So whether it's bubble-derived CPAP, ventilator-derived CPAP, CPAP from an infant flow generator type of system. We will not talk about this last one, which is high amplitude CPAP, or Seattle PAP, it's now called. There are some new studies, new trials that are just going on with that. So hopefully in the next couple of years, that will be in addition to this kind of conversation. And then nasal ventilation can also be done in a variety of forms, but again, that will be a different talk. So we often talk about high flow or CPAP or non-invasive ventilation, but we almost never really talk about the interface. And this probably may be more important than anything else in terms of how we manage patients on non-invasive support. There are marked differences between a delivery of flow or gas or volume from, say, a high flow cannula versus a RAM cannula versus a standard CPAP prong versus a mask. And one of the major differences is that this is related to the impact of resistance across these systems. So the higher the resistance, the less pressure and volume and flow you will be able to transmit to your patient in terms of trying to support their lung function. Ideally, one would want to use a system which minimizes the resistance effect on these pressure delivery. And so you're looking for things that might deliver the best pressure would be those with the lowest resistance. So face masks, certain types of prongs seem to have much lower resistance, and these are all standard CPAP types of interfaces. The ram cannula has a very high resistance across which gas must flow, and so it may have a negative impact on terms of how much pressure or flow can be delivered. And in that context, there actually is a very recent publication which demonstrates very nicely that, in fact, the mask interface does deliver a higher airway pressure, shown in this little blue box, compared to either a standard Hudson CPAP prong or the ram cannula, with the nasal mask being highest, followed by the prongs, and the cannula having the least amount of pressure delivery relative to the other two. If that's the case, one would think that maybe masks would actually be better as a mechanism of delivering non-invasive support to reduce extubation failures or to support babies with primary respiratory disease. And at least some small studies have been done in that context. This is information from meta-analyses that have been done, and here are the two studies down here. And both suggest that nasal masks may be more effective than binasal prongs for preventing CPAP failure. It's a fairly impressive reduction, somewhere between, about 50% in terms of the effectiveness in terms of minimizing failure. Unfortunately, the numbers are not big enough probably to demonstrate any difference in BPD further down the road, but that perhaps will change over time if there are larger trials to look at this particular specific approach. So we're going to go into nasal high flow therapy, which many people think is perhaps the gentlest way to provide non-invasive support. But the question is it better? Is it the best way to do that? It's clearly used a lot. This is a study, this is some information I have from a good friend of mine who leads the research enterprise for MEDNAX, which is a large neonatal consortium in the United States. High-flow nasal cannula first became available about 2002 here and rapidly was accepted as a non-invasive support mode, and by simply within just 2 years surpassed the number of babies being treated was surpassed CPAP alone, which is shown in this yellow line. They both kind of went along steadily, but over time CPAP approach has improved, and this black line here is ventilator support days. So the number of babies who are actually being supported just with a ventilator at any point in time decreased over time. And by 2010, high flow use had exceeded ventilator day use. So this was rapidly adopted and accepted in the United States. Interestingly, the first published randomized trials, which came out of Australia and then the United States, weren't done until 11 years after the introduction of therapy, so a common problem in neonatology. The respiratory epithelium is very delicate. It's very sensitive to changes in oxygenation and humidity, and in fact, ciliary function and epithelial cell function rapidly decrease when this tissue is exposed to lower temperatures and or decreased humidification. And the proper functions of the nasopharyngeal tissues are to actually warm and heat this gas before it gets to our lungs. But if we expose those tissues to high levels of gas flow that are dry and humid, even the nasopharyngeal tissues will become damaged and will not function properly. So that is primarily one of the main mechanisms of action for nasal high flow therapy, to condition this gas that minimizes work of breathing, minimizes metabolic work, improves epithelial integrity. It also does improve mechanics. The flow is thought to have let me see if I can go back up on that, have an effect on washing carbon dioxide out of the dead space to improve ventilation. It also decreases inspiratory resistance, augments tidal volumes when the patient is breathing, and offloads diaphragmatic activity. These are all somewhat in the same context as CPAP does. Although CPAP does not as effectively wash out dead space as high flow nasal cannula, interestingly. And then it does deliver pressure, but it clearly does not deliver the same amount of pressure that standard CPAP interfaces provide. It does, however, deliver enough pressure that we can measure improvements in expiratory lung volume and demonstrate improvements in oxygenation. So what does our evidence show in terms of randomized studies that compare high-flow nasal cannula or nasal high-flow therapy to other approaches to non-invasive support? So the first question I would ask you, and this is what I pose to our trainees, is that randomized trials suggest that nasal high-flow therapy is as effective as nasal CPAP for the management of RDS and the prevention of BPD. Is this true or false? Well, if we look at meta-analyses of now the multiple studies that are out there, and this is kind of a dirty meta-analysis, we've simplified a version of it, well over, probably now 1,500 babies have been involved in trials. And in terms of looking at the effect on post-extubation risk, there is no evidence that one approach is better than another. So high flow and CPAP appear to have similar effectiveness at preventing a baby who has been on a ventilator and is being extubated to remain extubated. On the other hand, if one looks at the use of high flow as a primary approach to respiratory distress syndrome, so a baby who comes out and manifests signs of respiratory distress, grunting, has a granular appearance to the x-ray, is on oxygen, the evidence would suggest at this point in time that CPAP is a much better tool and a much more effective approach at treatment of that baby to minimize the probability they will need to go on to require mechanical ventilation. And again, we're trying to minimize that exposure. So the question that I asked before that would suggest that that is a false question, that is a false statement, that in fact CPAP should be used as the primary approach to RDS. But once you have a baby who's stabilized on mechanical ventilation who you're extubating, there does not seem to be a benefit of one approach versus the other. There is absolutely no evidence on BPD. The trials have not looked at that as a primary outcome. The numbers are fairly small, and in fact, most of the trials have not involved this very small population of babies. So babies less than 28 weeks, where in fact in the European, US communities, that is the group of babies who develop BPD. So we cannot say that this approach has a preferential effect on BPD or has any effect necessarily on the rates of BPD. A lot of additional trials are needed or studies are needed, and this is just a list of some of them, and I am not going to belabor that, but there's much more to do in this area. We do have a consensus agreement that we developed now 3 years ago that basically this is a consensus of international experts. We came up with some ideas, and I think the key elements of this are that you need to have some degree of air leak with this interface. The preferred ratio of the canal to the nares is about 50%, so there has to be a leak to allow that gas to flow in and out. And that there is no evidence yet that supports clearly the effectiveness of this particular therapy in very small babies. And that, like CPAP, one should wean the oxygen first before weaning flow. So like CPAP, you would not wean your pressure until you get your FiO2 to a certain level. Excuse me. And then there's several areas of disagreement. And the most important is that if you're not doing well, when do you switch? We don't know that for sure. And when do you come off? We do not know that for sure. I think some of the future studies that we need to look at are the effects of, excuse me. The effects of different approaches. This one particular effects of different approaches. This one showing that, in fact, single prong nasal cannula ventilates far better, shown on these blue areas, particularly at higher flow rates than the use of a double pronged cannula, implying ventilation CO2 removal, that it is more effective the more flow you have that causes washout of that dead space. And this is a very nice study that came out of England recently, showing that in certain types of nasal high flow systems, you can have automated control of oxygen delivery, which minimizes the swings that you may have in oxygenation and may optimize the ability to keep the baby in a specific targeted range of saturation range, so that you minimize some of the effects of hyperoxic injury or hypoxic injury. So let's talk a little bit about RAM cannula now. RAM cannula was a system that was designed to interface specifically with the ventilator. So it has a little adapter here that connects directly to the ventilator, which nasal cannula systems have not had in the past, and allows then a interface with the baby that is a little bit gentler and easier to apply for the nurses and respiratory therapists, and allows it to be used with a little bit more ease at the bedside. So again, it was designed to try and minimize some of the traumatic effects of standard CPAP interfaces. It was thought to be gentler, but again, is it as effective as that approach? So the question for this is, are randomized controlled trials, is there evidence that this cannula delivers positive airway pressure similar to standard CPAP interfaces? And is it comparable to CPAP for the management of RDS and BPD prevention? Again, is this a true or false statement? It's a complicated question, but there are now multiple studies, and this is just one of them, that show us that when you apply CPAP or pressure through a RAM nasal cannula, you have significantly less pressure delivered. And so the gray bars here are the pressure delivered across a RAM cannula versus the darker bars, which are the pressures delivered across standard CPAP prongs. This is a more complex slide, but basically we'll break it down very quickly. This box A is a model with a closed mouth and full prong insertion. And when you have 100% occlusion, which is not the manufacturer's recommendation, you actually get pressure delivery that is fairly similar between a large bore RAM nasal cannula and a standard CPAP prong. However, as the occlusion decreases, so from 100% occlusion to about 80% to about 60%, the pressure transmission decreases fairly markedly. When one opens the mouth in the same experimental setup, the pressure delivery is dramatically decreased for all forms, including standard CPAP. So here we've gone from a pressure set of 8 to an actual delivered pressure of 3 when the mouth is open. And the same thing happens if the prongs aren't fully inserted, except you have lower pressure delivered with the RAM cannula interface. There is currently only one randomized trial out there looking at the RAM cannula versus standard prongs. Comes out of Turkey. It's a relatively new trial. It's fairly small, but it does look at these two for the first time. Primary outcome was the need for mechanical ventilation or surfactant in the first 72 hours. So this was as initial treatment for primarily for respiratory distress syndrome. Babies were approximately 29 to 30 weeks on average, and they were similar in all other capacities. And what's important about this study is it showed that the RAM cannula was not as effective as the standard prongs, with the almost 3 times higher rate of mechanical ventilation in the first 72 hours when that was the randomized approach used, and a much higher use of surfactant as well. BPD was not different, but again, this is not a population where we would expect to see a difference in BPD, even if one had to use brief periods of mechanical ventilation and an intervention with surfactant. So it is important to note that the RAM cannula is not approved as a CPAP device or interface, at least not here in the United States. You must be aware that if you are using this interface, there is a significant pressure loss across the tubing. Some of that is due to the tubing itself and the resistance of the system. Some of it is due to leak around the cannula because it's not supposed to be occlusive. And as you try to increase flow, if you increase flow in an effort to try and increase pressure delivery, you in fact will probably have less pressure delivered because of the effect of turbulence on the system. There are some design changes that are being developed by this manufacturer, and so perhaps this will all change over the next 5 years, but at this point in time, this is where we are. So in the context of nasal high flow and RAM cannula, is it really, it's gentler, but is it really better? It does not appear to be so, at least particularly as a support mode for primary respiratory distress. I'm not going to talk about nasal ventilation specifically, but I do want to just show a couple of slides why it might not be a better way than just using CPAP alone. When we normally breathe, our glottic muscles relax, so that decreases the resistance of our upper airways, allows gas to flow in more easily, and there is an active process of doing this. So there are actually glottic muscles that open our airways up more effectively. When you are on CPAP, this process does not change. It remains physiologic. However, when you start blowing ventilator breaths through the nose, there is an active constriction of the upper airway that occurs, as shown here. And so actually the glottis is trying to blunt that type of pressure or volume delivery because it is not normal, it's not physiologic. Interestingly, when one is on a synchronized approach, so in this case, NAVA, nasal ventilation, you have the same type of relaxation of the upper airways as you would with CPAP alone. And then again, here is a non-synchronized approach to non-invasive ventilation. And even further interestingly, the same thing happens if you're using a nasal high-frequency ventilation approach. So, and that's probably because it doesn't produce these large volume changes in high pressure deliveries to the nasopharyngeal tissues. So just keep that in mind. So is CPAP, it was the first thing we used. It's probably still the best. It's been used for a long time. Been here for well over 50 years now. Clearly has a beneficial effect. It's widely available. There are multiple approaches. But as we noted before, it's not necessarily the easiest thing to use, and it really does have a learning curve. So this is a nice little study by Hani Ali, who trained at Columbia in New York City and is an advocate of nasal CPAP, where he basically has shown that in a pre-CPAP era, one kind of still has a lot of CPAP failure when you first bring it in. And over time, the CPAP failure gets better. The earlier you use it, the better. Surfactant use decreases as you get better with the use, and BPD rates eventually drop to fairly significant lower levels. But it takes time. This is a matter of years, not a matter of weeks or months. We talked a little bit about interfaces before, but even all the bubbling systems are not the same. So there is thought to be some importance in terms of how much amplitude one gets with the bubbling system, how much bubbling pressure difference is created there. And different systems have different effects on that. This particular system has a diffusing component that actually completely blunts the bubbles before they come out of the system to the CPAP interface. And so there is some question about, is that an important element of CPAP, particularly bubble CPAP? And so just being aware, different systems have different effects on bubbles. We also talked briefly about different interfaces having different effects. This is the Seattle PAP system, which I'm not going to talk much about, but it creates very large bubble changes, and it's related to the angle at which the CPAP cannula or prong system comes into the water and how those bubbles get generated. And is one bubbling system, one system for CPAP better than another? We don't really know. There's really not large head-to-head trials. This is one trial out of England which looked at this and basically suggested in this particular study that bubble CPAP had less failure than infant flow drivers, but there are other studies which suggest that infant flow driver systems do a better job of gas exchange than bubble. So we don't have answers for that particular question. I think the most important thing is the program, is how are you using it? And it's probably just the same as it is with ventilators. No matter what ventilator you use, if you're very comfortable with it, if you're very good with it, and if the practice in your group is comfortable and has experience with it, you're going to do better with that system than with something that's new. Aggressive nasal CPAP programs have clearly showed significant decreases in ventilator days and in BPD rates. And these have been published out of the US. They've also been published, a very nice study out of Germany, which shows the impact of the program, of the whole setup, all the people that are involved, as well as nuances of other areas of care. Just briefly, this is kind of a quick thing related to the US studies, where this group in blue here is the group at Columbia, which has by far the lowest BPD rates in the United States. They use CPAP very early. They have minimal surfactant use, and they have extended CPAP use, so their babies stay on it for a fairly long period of time, as opposed to a couple of groups or hospitals in Boston where they did not use CPAP early, they used mechanical ventilation early. Their BPD rates were considerably different. And this meta-analysis is just to kind of re-emphasize the fact that a complex approach may have a more effect on BPD and success than just thinking about just CPAP. So in this particular group of meta-analyses, the effect of using less invasive surfactant coupled with non-invasive support is associated with the lowest risk for development of BPD, as opposed to any specific interface that was used, or just the use of non-invasive, of Ensure, a different approach to surfactant delivery, where you actually have to put the endotracheal tube in place. So to kind of summarize this, what should you use and when should you use it? And this is going to be my personal recommendations. You should use A, what you're most familiar with, and B, what is most effective. So if you can combine those two, that obviously becomes the best way to go. Some of the other things to consider is what's the least invasive approach and the least costly. So if you could get a system which is least costly, very familiar, very effective, and less invasive, you're likely to have a much better outcome. The best studied and most experienced is CPAP, and in my opinion, that should still probably be the default mode. I think it should be considered for all babies greater than 26 weeks, perhaps greater than 25 weeks, as the initial approach to respiratory support before even intubation. Within the context, one would then also include the use of MIST or LISA to use surfactant delivery and continue to support the babies non-invasively while you're doing that. It probably also should be the default mode for most babies who are born less than 28 weeks, simply because we don't have enough evidence from the nasal high flow therapy literature to suggest that that it is as effective in those babies as CPAP alone. The optimal interface is probably the mask, followed by the prongs. The optimal driver is unknown at this time, but probably something that uses a flow generator approach where bubble CPAP would be better than just using it with a ventilator if you have that capability. And then we still have a lot of studies that do need to be done. I'm not going to go into non-invasive ventilation again. I think you can consider high flow therapy in lieu of CPAP if you're extubating from a relatively low mean pressure. For us, that's usually a pressure of, say, less than 7 or 8 centimeters of water on a ventilator, be it a conventional ventilator or a high frequency ventilator. It is clearly more effective when the FiO2 is less than 30% as well. And so actually Brett Manley and his group have suggested a 30-30 rule for babies who are being managed on high flow, that if you have babies who are under 30% oxygen and 30 weeks of gestation or higher, they probably are going to do just as well on high flow as CPAP. but babies who are smaller and on higher amounts of oxygen probably will need that CPAP support to help maintain their end expiratory lung volumes. And then I think the most important aspect of all of this is bundled care. Best outcome centers use care bundles that incorporate all of these. They have a champion who leads that effort. It takes time and training. And actually the evidence suggests that the use of these bundles is much more effective in terms of improving outcomes than any single intervention that we might add. So comparing a single intervention trial to a trial or a study where you have multiple interventions that all may have an additive effect on the outcome you're trying to improve, do better than just a single intervention approach. So there's a lot of unanswered questions, so I'm not going to get into all of these, but there are many studies and many trials that we still need to do to help us in terms of the overall approach to management and then optimizing the care we give to these babies. My conclusions are shown in the next few slides. Any form of positive pressure contributes to lung injury, can have systemic effects. Non-invasive is an important adjunctive therapy, and there really are very few contraindications to its use. There's limited evidence to suggest the optimal non-invasive approach, but I think nasal CPAP coupled with less invasive surfactant is currently that approach. And then each unit should develop a bundled approach to optimize this support method. So with that, I'll stop and we'll try to answer any questions. And I thank you for your time and thank you again for the invitation to participate in this series.
Well, thank you so much, Professor Yoder. This was an elegant, very comprehensive lecture covering a topic I know is so important for neonatologists and of interest for neonatologists all around the world. So thank you very much for this very clear and good message. We have approximately 15 minutes for question and answers, and we have already received some questions. So, Professor Yoder, are you prepared to answer some questions?
We'll try.
Yeah, we do our best. And so I think I start from the top here. What is the minimum flow to be considered high flow therapy?
Well, that's an excellent question. There's not a specific answer to that. We use a minimum flow of 2 liters per minute, but it's probably, and there's no good reason for that. That's just a number that was selected. Different people will come off of high flow therapy at different levels. The Australians usually come off at 4 liters, but that's related to their the way their system operates, not from a medical economic perspective, not from a patient care perspective. I think it better, rather than talk about a specific flow that's too low, I would suggest when should you stop humidifying and heating the gas? And I think that relates more to the size of your patient. So one has to remember that the standard inspiratory flow rate for a baby is 1 liter per kilo per minute. So a 1 kilo baby, when they breathe in through their nose, their peak flow rate is about 1 liter per minute, or 1 liter per kilo. And so if you're using a high flow system, I think perhaps the better way to think about it is you want to think about, are you optimally supporting or exceeding that flow? So in pediatrics, for example, 2 liters per kilo is what they typically use because that appears to minimize the work of breathing of the patient and provide additional positive pressure support. Now, clearly we use a lot higher flows in the small babies. Many people start at 6 to 8 liters, even in the 1 kilo baby. So you're far exceeding their normal inspiratory flow. And so there you're trying to somehow optimize gas exchange. But I don't think there's really a minimum flow rate. We will put some of our very small babies on a nasal high flow system, but we won't call it high flow nasal cannula. We'll just call it heated humidified gas flow, simply to protect their upper airway. So they're getting warm humidified gas rather than dry gas.
Yeah, thank you. And then the next question, I think you answered that in your lecture, but I can still ask it. What is the best interface? I think that was part of your conclusion slides. But
when we want to optimize our non-invasive support mode, we use a mask. We find that we have our babies are most comfortable. Well, I won't say they're breathing. Their work of breathing is the less we get the best pressure delivery. We have the lowest FiO2. The problem is that with the CPAP interfaces, you get pressure on tissues. And so we're frequently moving back and forth from a mask to a prong, to a mask to a prong. But I think in terms of just the best interface, masks deliver pressure best and have more demonstrated improvement in lung function.
okay, thank you. Now I have a comment for Gianluca Lista. You had a comment. Could you write it down, Gianluca, or? No, okay. So then I misunderstood. That's okay. Next question. How much CPAP pressure do you reach before shift to invasive ventilation?
We typically will go now. Our practice has morphed over time. We typically will go to as high as 10 or 12 centimeters of water as pretty much a maximum. We usually don't go above 12, but I know there are studies that are being developed out there to look at, is there a benefit to that higher level versus levels of say 5 or 6? And is there a risk associated with that? I think that's the biggest question.
Yeah, I guess so. So that's the relevant question. Yes. So if NIMV is not better than CPAP, how come studies show an advantage for NIMV over CPAP after extubation?
Well, the studies that have shown a benefit have all used synchronized approaches to NIMV. And most ventilator systems do not have the ability to synchronize. So I think that's very important. There are some European ventilators that do synchronize, and if you have access to those and you use those, you are probably going to have better success non-invasively than with just CPAP alone. The NAVA system in the United States is a system that does that, but the studies have not been done to completely demonstrate what the relative effect is of those. So we don't know if they actually improve the long-term BPD outcome. The large trials and the meta-analyses would suggest that just a generic approach to non-invasive ventilation, it may decrease extubation failure rate, but there does not appear to be a signal for BPD. Again, I think the key there is it synchronized or not? And I think if you have the ability to synchronize, you're probably going to do better with that approach than you would with just standard CPAP. Because that approach allows the normal physiologic processes. So relaxation, it ties in with the diaphragmatic activity, and the system is working together as opposed to working against each other.
Mm. Okay. And then a question from Akash Sharma. Do you think that trials could incorporate for differences in MAP while comparing CPAP and NIMV?
I'm not sure what MIP stands for.
I guess it's mean airway pressure.
MAP.
Yeah, MAP.
Could you repeat that?
Yeah. So now that they removed it here, so if I can get it back.
It's in the answered questions in the second.
It's in the answered questions, yeah. So let's see if I can find it back here. Do you think that trial should incorporate for difference in mean airway pressure while comparing CPAP and NIMV?
Yes, okay. Yeah, I think that's a really important question because when one uses the nasal IMV approach, the thought is if you have the same, say, distending pressure of, say, 6 or 7 with CPAP and that, but then you're adding additional pressures with ventilator-supported breaths, the mean airway pressure is going to be higher in the non-invasive support mode than in the CPAP mode. The same would be true if you were comparing, for example, ram nasal cannula to CPAP, where if you have the same pressure set, we know the ram cannula doesn't deliver as much pressure. And so you have differences. So, I mean, ideally, one would want to actually be able to measure the airway pressure that's being delivered. I don't honestly know, we haven't made that adjustment for mean airway pressure in those types of trials. And I don't honestly know if it makes a difference, but theoretically, if the amount of pressure you eventually deliver to the lung and to the airways is higher with one approach than the other, you might think that approach would be better.
Okay, and now we have a question from Dr. Luciati from Jakarta. Why do you suggest to change to high flow from CPAP when the baby still needs pressure and oxygen? Why don't you suggest to keep baby on CPAP?
That's a really good question. Most of the time, what's happening in those situations is if you have a nursing staff that is very comfortable and a respiratory therapy group that is very comfortable and knows how to minimize the pressure-related injuries to the nares and that CPAP systems can produce, the evidence would suggest that's perhaps the best way to go. Many nurses, many parents like to have better access to the babies, and they feel they can do that better with high-flow systems. Now, the real question is, in my mind, and I think that of many people, we don't know, but there is clearly pressure delivery related to high flow, depending on how it's used. And so is it actually better to stay on CPAP at, say, 5 centimeters of water pressure and 21% oxygen with all the difficulties of maintaining that system, or is it just as good to switch over to a nasal high flow delivery system, which may deliver 2 or 3 centimeters of water, so not as much pressure, but continue to support that baby? We don't know the answer to that question. At this point in time, I think there are studies that are beginning to investigate those specific questions. And, but I think at this point in time, if one were to pick the optimal approach would be to stay on CPAP support.
Yeah. We have a couple of minutes left, and we have now more than 40 questions. So I just want to remind everybody that we'll try to answer these questions later, those who we are not able to cover live. And you can read the answers on the UENPS webpage within a few days. So I think we have time for a couple of more questions. What should be the ideal CPAP pressure? Some recommend very high pressure of 15 after extubation in extremely low birth weight babies. I think we touched about that before, but
yeah, we don't know. We don't know how high you can go safely. Back in the 70s and 80s, people did use higher CPAP support pressures. They had problems with increased air leak and decreased CO2 removal, but that was in pre-surfactant era, so I don't know that we can translate that to the current times. There aren't studies looking at higher pressures really above 8. So Bancalari's group studied 5 versus 8 and found that 8 was a better CPAP level to use. The people at Columbia routinely use only 5 and maybe 6 centimeters of water and have excellent outcomes. So there's no evidence that one pressure level in the long term is better than the other, and we need trials to look at that.
Yeah. And I think this has been a question during at least 40 years I've been into this field. So, okay, one final question. May I know the highest PEEP which may be used on nasal CPAP?
The highest?
Yeah.
I don't know.
No.
Sounds like 15 might be.
Yeah, it's pretty high.
But we don't usually, we don't go above 12 routinely. I would say maybe sometimes somebody wants to go a little higher, but I think at that point in time, if you're not able to effectively support your baby, maybe you need to think about giving them a break, trying to find something else to optimize how the lung functions through with support by mechanical ventilation, and then give it a try a few days later.
Yeah, we could go on for an hour with questions and answers, Bradley, but I think our time is up. And I will once more thank you for this excellent presentation. And I know that it's very early in your time, so thank you for sharing this with us. And then before we close, I just want to remind you about our next webinar lecture. It's on the June 23rd, the same time, 2 p.m. And now it's our president himself, Professor Moretti from University of Rome, together with Professor Gysi, also from Rome. They will talk about non-invasive ventilation. So I look forward to welcome you all back on Tuesday, and thank you for your attention. Thank you for all the questions, and once more thank the speaker, Professor Yoder, and again I also thank MCA for excellent technical support. So with these words, I will close the session, and goodbye.
Goodbye.
Thank you.
Thank you.